Welcome to another episode of Out of the Fire podcast, where we bring on experts across the healthcare industry to talk about their experience with fire. Eyal, we're hoping to learn some really interesting insights today in this conversation about things unique to Israel and then how fire has really been implemented so far and what you can share with people from across the world that, fire is international.
Introduce myself shortly. As you said, my name is Eyal Dviri. I'm the head of data innovation team in Clalit. And let's start from here. Clalit is arguably second largest payer provider organization worldwide. Kaiser is number one. Clalit is number two. We have 14 hospitals, 8 normal hospitals, and more pediatric, mental health hospitals, and rehabilitation hospitals. And we also have the community. Okay, Israel, let's talk about ecosystem, okay? Because ecosystem is everything, especially when you deep down to fire, you need to understand the settings because there is no one solution fits for all. So in Israel, it's a public healthcare system, meaning the government paying for it and the citizen pay for the government in order to be insured, but everybody gets treatment, which is very, very good because data-wise, obviously for the people, but data-wise is very good because we have data from all levels of population, poor, rich, old, healthy as well, which is very important because it doesn't cost you money to go to your local doctor, your community doctor, and you just set an appointment and you go there. In Israel, the era of digital, let's say, digital health started quite a while ago. We started in 2000, year 2000 in Clalit. So we have a health record since 2000, and we all combine them in one SQL server, data warehouse, which all the data resides, but it's not, it doesn't have terminology necessarily. Sometimes data which came from one hospital doesn't match the other one. Name of department, like one can call the ER with a dot, one without a dot, one room, one center, and it's a big chaos. But we operate with this for a long, long time. Israel also have, which I think will be interesting for the community, fire community. Israel have, it's now start to become a legacy, a way of CDR, network based on CDR, which you can transfer data from the health organization, hospitals and so on, to a central repository, and everybody can have a look at the patient data. But it's on PDF files. You cannot download it. You can copy, but it's not, you cannot run AI prompt on it. You cannot embed it in your ML procedures. And it's not exactly accurate because there's a way around it, but it's not modeled. It's supposed to be modeled, but it wasn't, it didn't happen in reality. In reality, although the terminology, it's not always translated to terminology and so forth. So this is what existed before fire. Exactly last year, July 24, a law passed in Israel. It's called Portability, Medical Information Portability Act, which means that you must share your data with fire, based on fire. It's not part of the law, but it's part of the layers above the law, the regulations. I think the community in Israel really embraced it. Okay, we can see a tendency to go there, which it's very good because it's solving a few other problems, because until AI, we didn't have any use for text. Text was mainly to transfer, the doctor can read it. It's not part of the IT because you didn't have tools to deal with it. And now with the AI, we must deal with text. So we must rethink our systems. We must have it near real time, at least, if we want to give patient-centric, predictive, and individual recommendation. And this gives us a great opportunity to go to near real time. So actually the law states that I said at the beginning, 5 seconds, I think. Later it's become a bit larger, but let's say 5 minutes after record was created in the EHR, it should be ready in fire ready for use by other organizations. So this is the end of year one. The program or the plan is to go up to 2030, but actually in 2027, we should have the basic or the initial interoperability based on FHIR, which is very good news, I think. And we're rebuilding our system. This is, I think, one great advantage of in Israel, at least, because you rebuilding your data foundation from scratch is much better than I have it already in FHIR, but it's not accurate. It's not, and it didn't have to be accurate before. But now, when you want to, well, obviously better accurate. But now with the AI, you cannot allow yourself to depend on data if you're not sure it's good. Because without AI, the doctor, the MD, the practitioner, it's his problem, right? It's his problem to ask the patient, tell me what allergies you have. Are you allergic to penicillin, for example? When you based on data, you cannot have mistakes, especially for AI, because I give the example of Waze or Google Maps. The moment you trust the system, you start forgetting, or you don't implement your own decision making. You say, okay, he's right, almost every time. And I have many stories how I took the wrong advice of the Waze. Even I knew there's no reason to take the right. I should go left. But he told me, I said, okay, I don't know what happened on the left side. Let's go right, as he said, and it was a mistake. So this is the situation now in Israel. We really working hard on it. The community is very strong. We have very good leaders of the community, which is non-profit organization, and we collaborate very, very well, I think, with the Ministry of Health and the HMOs. Okay, I didn't mention, as part of Israel infrastructure, healthcare infrastructure, we have 4 main HMOs, which means they are payers and they are community providers. So if you have a sore throat or you have ear infection, you go to your local practitioner in the community, and this is the HMO responsibility. If you go to hospital, you can go to private hospital, you can go to Clalit hospitals or to Ministry of Health hospitals. And yeah, so I'm very excited. It feels that we are in the beginning of the process, but I think we take it very, very seriously. I think our main problem, like I think many other countries as well, is that we have a lot of pressure from the AI, from the business people, to deliver AI solution fast, actually, because there is a competition. We need to win, although I don't understand what in public health system we need to win any competition. But okay, we have to win, and we have to deliver, and we don't have time to wait for curated data, FHIR data, with all that evolve around it. So this is the tension we have. We are running as fast as we can to FHIR. On the other end, other teams running as fast as they can to AI, and they won't necessarily meet. And this is one of the things that I really try to advocate, that maybe you can present another solution or the community will think about. But I think we just need to double our funding. Just push the timetable. Don't give up. It will happen. It just need to happen faster. And it's nice to say it, but you need to get the funding. And you need to get the people, because as you might have seen in the FHIR and HL7 survey, number one, and everybody is saying it everywhere, it's manpower. People still don't know. There are not enough experts in FHIR, and this is a big gap. I hope there will be some initiatives that will open maybe a school for FHIR. I mean, don't take somebody who knows SQL, who knows data warehouse, who knows databases in general. Just take somebody from university that it's very hard for him to find an entry-level job, right? It's very hard now, because you don't need entry-level jobs because you have AI. So take them into FHIR. Let them use AI tools to make it faster, okay? Because it's possible. It's possible. Just if you go deep, you have really to invest a lot of time. But I don't see any real reason not to make it faster, beside money, time, effort, and actually, just to bring on board the decision makers, the government maybe. So maybe this is
Yeah,
my call
so
for the community. I think there is not enough push from the AI side. I mean, if the AI people will come and say, look, we don't want to work on data that sometimes mean that, sometimes mean that. We need to understand the schema, and we want to give the AI, a short description of what is this data point. And this FHIR do excel at it, okay? Implementation guide, I can feed it to the LLM. They were trained on FHIR schema, because if you ask them, they know how to give you schemas very, very well, actually, resources and so on.
yeah, that's a great point. So you brought up a number of things. Let me just get back to a couple of the things as takeaways of everything you mentioned, which is fascinating, by the way, because I think that it's a little bit of a similar thing going on in the US in terms of there's mandates that have been put in place. There's obviously the Cures Act that took compliance to a new level, so mandating patient access APIs. We have TEFCA, which is like a nationwide exchange. Is there an equivalent of TEFCA in Israel? Yep. And then in terms of it sounds like it's pretty similar to how the US interoperability works right now, where you have CCDAs, which are basically the documents that are being exchanged with your PDFs. And even now, there are some FHIR connections like utilizing TEFCA and other, but it's only like 10%, less than 10% is utilizing FHIR currently. So we've seen that's kind of slow uptake. And one of the questions I wanted to ask you is, like, in Israel, we see what I think is what a modern healthcare system could be, and our cost on the cost curve, Israel has managed their costs, like I would say, a lot better than like US has, right?
Well, it's
US,
not
yeah, so US spends by far more on healthcare than anybody else. I think by a factor of 2 or 3, and it's basically unsustainable. Everybody understands that you can't have healthcare be like a third of the GDP and keep going the same direction. Medicare is gonna at some point go bankrupt. All of that kind of thing. I think the lessons from Israel is that there's cooperation from a public and a private model, and then a provider payer community public health together does enable this. I think Israel actually has a pretty good overall health outcome. Average life expectancy is up there. So what are those learnings, and where you think the FHIR will help drive AI? Because AI ultimately in and of itself, right? Like, it's just a tool to get us to that promised land of better outcomes and people living longer and having better care for your family and your community. Where exactly do you think FHIR fits into that? Because, like, I think a lot of people will say you have these LLMs, you have a lot of purpose-built LLMs, on which there is an argument right now in the industry, like these large language models.
Because they can understand what.
Yeah, they can understand the raw textual notes. And if you have an AI scribe, you have AI scribes basically annotate what has happened. So they're essentially writing that clinical record. But if you don't store it in a consistent semantic representation, right, you don't have ontologies, you don't have terminology that has been, you're talking the same language.
You're still in silo. You're still in silo of your own organization.
Right.
And I try to answer you because it is a question that is reason again and again. I think this way: if you need to have all the data of the patient, let's say I'm going to a hospital. I say I have a stomach ache, and 2 weeks ago I was hospitalized in other hospital, and they send me to MRI, let's say. Okay, maybe this hospital knows about it, maybe he doesn't know about it, maybe he prepared an algorithm like triage if they send me to MRI or not. Okay? If he won't have this data, he cannot give me the correct recommendation, and it can be even dangerous. Let's say, different example, I'm insured of one HMO, and I go to the hospital, and let's say they have my general data because they have the PDF, they can look at it, but they cannot run it in AI model. Now, let's say, okay, I took the PDF and I did skin scraping or whatever, and I fed it to the LLM. Can you trust it? I mean, you cannot even trust what humans typed in coding, because obviously there are many mistakes. So this is one aspect. And the other one nobody can use it. I mean, you can use it, but you cannot sell it because your data structure is different than the others. And eventually we should be a market sort of that you can pick your solutions and you can run it in Israel, in your HMO or the hospital, or in the US or China for like care. And what FHIR does, it's not holy. FHIR is not holy. It's just give us structure like language. Even the LLM talks in correct, let's say English, correct grammar, correct vocabulary. And this is what FHIR is about, in my opinion. Just take the data, understand it, because we told you what everything means. We told you that don't trust this data in provenance. Let's say I said, this diagnosis, I don't trust it because the source is not good enough. Or even better, take the record, run the AI on top of it, and add in the provenance or other extension, what do you think is the right data inside? For example, the doctor wrote, you have, I don't know, something, sore throat, okay? And he said it's made of bacteria. And the AI reading the notes, reading the lab results, reading everything can add, in my opinion, the diagnosis is something different. You won't change the record, but you can add. This is a good way of structuring the data with AI. But don't mistake, the metadata of the record must be structured, in my opinion anyway. Who created it? When he created it? How many times it changed? Did it ever change? Maybe even I got it from a different hospital because I used FHIR or other method to pull it in. And now I transfer it to a third party. Does the third party need to know I didn't create a record, somebody else did in different organizations even? So all of that, I think, must be structured, must be constructed, must be organized. Use the LLM, use the Gen AI in order to make the record better. And I take you to another thing. Okay, let's say schema is not important, terminology is not important, AI will do everything. Let's say. How will you transfer the data between the organization? You still need a solution to do that. Okay, you can send it by email. Well, you want. You can send it by disk and key. You want. You must have an API connection or some digital way of transferring the data reliably. And this is what FHIR is all about. FHIR is, in my opinion, what one is three major parts. One is API engine. This is the most important one. The second is schema, and the third is terminology. And the rest is how you enforce it and other tools.
Yeah, and I like that focus on that you brought up provenance, data lineage. So I think it is absolutely a must when implementing FHIR solutions, and that's where I think a lot sometimes in the United States, I know in the U.S. core, provenance is part of the data set in the implementation guide, which is interesting, but it's not like a mandated thing. So like right now, when you connect to, for example, Epic or Cerner, you rarely, if ever, get any provenance resources back, right? But they're a part of this. There's an initiative called the Sequoia Project in the U.S. I'm sure you heard of it. Also, as they're implementing TEFCA, they're recommending data usability standards. And one of the big things about that is like you really don't know the quality of the data. It all starts with the provenance, right? So it's like if you're an art dealer and you go to an art gallery and you want to look at a painting, the first question that the dealer asks you is like, where did this come from? You know, it's not just about who the author is. It's like, can you track the provenance to how you got this painting, right? And then you kind of can tell whether it's authentic or not, et cetera. So I think every healthcare organization I think that's where there's a lot of interesting conversations we can have about where it's similar to the banking industry or where it's not, so I think in banking, you can go to your credit card provider, your bank account, and you can add, if you have another bank account or another credit card, and it's not really going to, tremendously change when you're looking at your finance. You're in your financing. Yeah. Here's another account. Yeah. Here's another account. You're good. This is where your money is. But when you have healthcare, it's a little bit of a different story, right? Because you're like, oh, you went to another hospital, you went to another hospital system.
Even when you deal with money, you are accurate, very, very accurate, because if not, you will lose your job probably. But in healthcare, if the doctor or if the MD practitioner write different mistaken diagnosis, nothing will happen because you write in the text everything that you think so. We didn't find the right diagnosis, something. The data is structured. And as you said, it's maybe 4 banks, 5 banks, 10 credit cards.
How do you deal with, so in Israel, the doctor can't see what you would call a longitudinal record of the patient, right? Because everything's connected and it's a one system. So it's not like you have hospital A on one EMR system, you have a hospital B on another. It's all one system in Israel. And then also HMOs and payers are part of that.
It's not one system. Every organization's transfer is push its data to this
To the
CDR.
system, right.
And there's a company that process it and deliver. But you need to enter a different system, right? Use a password and get the data. It's not comfortable to work with, but it is used a lot. But not everybody has permissions to do it. I don't know all the details, but I know it's not perfect.
It's not perfect, obviously. Do you feel like that's what is, important? And people talk about costs, right? So in the US, a lot of times when you go to a different doctor, they will order all the same tests, because every organization has its own. You can't trust these other tests that these other doctors obviously did because for some reason that's not good enough. We're going to run our own test. So a lot of the waste and a lot of the inefficiencies in the US is because of that. It's a revenue generating activity, right? Like your doctor there will order these tests and as part of. Do you feel like that's part of the benefit of having this kind of this true interoperability or even visibility of the patient activities, is that there is a mindfulness of we don't need to order 5 more tests because we already can see these. We can see the results immediately from this other.
Yeah, I don't know. I think because it's public and nobody care a lot about the costs. I don't think they will not order again the lab results, the lab tests. Maybe MRI, things that takes time maybe to do them and cost more, and it's fresh. They can have access to the MRI. Actually, MRI it will be different now. They cannot. So it's not an issue anyhow. I'm not sure it will reduce direct cost like that, but who knows? I mean, we need to trust data. And I know that in labs, every lab, I was surprised to learn that lab results are not, if you do the same lab result in 2 different machines in the same lab, you get 2 different results most of the times. So I wouldn't trust other hospitals. But interesting question, how we to reduce cost. I don't know. I think we will be more efficient. I think we can get a better data-driven decisions by this interoperability. Yeah. And I can compare it to TEFCA, it's a bit different as well, because do you want me to get into it? TEFCA, Israel, PCM, how the chain, the network, because network is everything.
Yeah, I'm interested in
network is the problem. Yeah.
If you feel like there's any insight to gather for TEFCA, because I think right now they're not sure where TEFCA is going to go, how it's going to fit in, whether we're going to have this mandate sort of continue and how it's going to be implemented. We've seen a lot of conversation from the new leadership, CMS, and for comment. But it's interesting. Can you maybe comment how it works in Israel, where it's you feel like there can be some learnings there? I
think so. Yeah, Israel solution, which is not existing yet. Okay, it's mandated by the law. It's written that must happen. So we have in Israel the PCM. PCM is Patient Consent Manager. His roles are actually to authenticate the request for data, and the request for data are not custom-made. You have to predefine a service. Let's say I'm developing algorithm for triage for MRI. So this is the name of the service, triage, MRI triage, or MRI stomach triage. And then I will define what resources or what group of resources actually I need, like diagnosis, imaging, lab results, whatever. And when the patient comes to the hospital and I want to evoke this process, what happens will be like that. I will send to the patient a text message, or what could be kiosk, could be different solutions. He must approve the request. It can approve it one time or for longer. Longer is up to 1 year or 2 years. It's not for life. And then with this consent, the PCM running the consent system. So the patient approve, consent the service in the PCM system. The PCM send back to the request to the hospital that requested the service, the approval of the patient, and tells him, look, you have his data in this place, and this place. Go and ask them. So it's like, I've read a lot about TESCA and the RFI that just came out. And yes, it's like directory of resources. And what is different from TESCA, again, it's services that are predefined and pre-approved. I mean, if you want to have this new service, the HMOs and hospitals can be against it, not deny it, different word. Anyway, they can say, I don't agree, it's too much data, you don't need lab result for MRI triage, for example. So they can argue about it. But again, opposite to TESCA, or maybe not opposite, but different from TESCA, patient consent is the main issue. And I think in this time and age, it's really a must. It's really a must. I understand that in the USA, it's a bit different, but I want to know every time somebody touch my records, like what you do with your credit card, with your watch, with the
NFC.
Yeah, NFC. With your watch, with your phone, mobile phone, every time you charge, you get a message. You were charged by this and that, this amount of money. We should have it the same. It's no different. Maybe not every time, maybe once a day. And also in Israel, it's part of the PCM. You can enter the website. Well, in the future, you can enter the website and see who connected to your data, who pulled it, who used it. And I think if you do it, I think it should. I think EDIS, is going the same way, the European data space, healthcare data space. I think they're going the same way. They're very strict on privacy and audit and logging and so on. And I think everybody should do that because it maybe will slow us quite a bit, maybe, but I don't want, everybody knows 1984, how you can control really every aspect of our life. Very, 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 very near. It's not far future. It's 2-3 years in front of us. And I really, really would like to protect my data at least. And just imagine somebody with anti-abortion and he can get an access or is below 17, went to the doctor, asked him, and then you can send people to talk with her and persuade her. And it can be a good cause, it can be a bad cause, but I want at least to know that somebody approached the
Yeah.
At least.
That's fantastic, God. And then, I think your point is that consent is such a huge part of that. And I think that that's the missing part right now of all of these initiatives where it is, we've just seen it's broken. It just doesn't work. And then, you need, OAuth 2 and you need federated identity and you need, things like, in the US, we have the CLEAR, which is kind of like a system to really identify who the individual is and then clear them essentially, and then reusing that for all the different healthcare services. It's been very slow going. Funny enough, it's not has taken off as much as I would think of it because it would save so much money for all the healthcare industry. But I think there is a lot of apprehension about people don't want to share data, and it's their privacy concerns. There's all kinds of government concerns too. Now in the US, I'm sure you know what's happening, but there's a lot of concerning things about government getting access to records. Yeah, rightly so. So I think that we need to have those systems in place and protections before kind of like all of this unfettered access by AI, and AI is getting, it's like order of magnitude better and better every couple of months. I think we're still far away from the general intelligence, but I think that even the level that it is now could be extremely concerning, right? For me as a user with a lot of health data and unfettered access by AI on behalf of even the well-meaning. Anyway, fantastic conversation. Maybe we can do it again sometime in a little bit when there's some interesting things to share that you've been working on. I really appreciate it, and I'm hoping readers, or rather listeners, of this podcast got some very interesting things about it as well, and it sparked something. So thank you very much. I appreciate your time.
Thank you very much. And I really believe that the interoperability is not just about data, it's about people.
Right.
What we did now, different countries, we connected by LinkedIn. I know Brendan, like I read Brendan every day, and interoperability is about that. Okay. It's about the people
Correct.
in India, the people in Germany, and so on, all connecting and trying to achieve something which is greater than what we have now and much better. Thank you very much.
Who you are as a human doesn't, you're the same human underneath, whether you're in one country or another, and healthcare is universal, right? So, it is everybody's right to access their data and use it.
And if you talk about money, which is the driver of the world, if we all talk the same way, we can sell product to everybody. It's not, the market is getting much, much bigger, and startups can have access. You always have to refine a little bit, but theoretically speaking, and it's makes sense even money-wise, not only to make life better.
Absolutely. I think I agree with that 100%. All right. Thank you very much, Eyal.
Thank you.
And thank you for listening to another episode of Out of the Fire podcast, where we try to hit on a lot of these topics about not just fire, but interoperability, healthcare, AI, and experience from all sorts of different implementations across the world. Thank you very much.